Hello, I'm Bob Challoner, the President and CEO of Southampton Hospital, and I'd like to welcome you to another edition of Focus on Southampton Hospital, your monthly program about the goings-on here at your community hospital. And today I'd like to welcome Nikki DeMatteo, who is one of our advanced occupational therapists, to tell us about occupational therapy. So welcome, Nikki.
Thank you.
First of all, tell me a little bit about yourself, how you got interested in occupational therapy, and also how you ended up here at Southampton Hospital.
Okay. Well, I was an occupational therapist since 1997. And when I started out my career, I did all aspects of occupational therapy, but my real love was for hand therapy.
Okay.
So through the years, there's several requirements that you need to become a certified hand therapist. And then after I completed what I needed to become a CHT, that's when I started focusing on hands.
And CHT, certified hand
Certified
therapist.
hand therapist,
Okay.
right.
And so, occupational therapist, let's talk about an occupational therapist as opposed to physical therapist. Most people I know are very familiar with physical therapists, and they assume that they all do the same thing. How is it, first of all, what's the training for an occupational therapist?
Well, an occupational therapist, similar to the physical therapist, will have basically the same schooling. I mean, you start out with very similar courses, and then like the last 2 years of your school, you kind of branch off into your specialty, where OT is a little bit more functionally oriented, and PT is a little bit more physically oriented with more movement and gross motor activity, as opposed to OT, which is more fine motor and using more functional kinds of activities to get the patient to the same goal. Like at the hospital setting, physical therapy and occupational therapy work together. What we try to do is to restore that patient to their either pre-injury state or pre-illness state, and to allow them to be able to function complete again.
Okay.
So in our setting at Southampton, what we do is physical therapy will concentrate on getting the patient back to their normal movement, maybe being able to walk again, not having to worry about their balance, really look at more of that gross motor ability for the patient. And in occupational therapy, we'll look at what that patient will do once they get home. Will they be able to dress themselves? Will they be able to do their buttons with their fine motor? Will they be able to cook a meal? So then we'll spend more time on their hands and upper extremity and try to figure out, will their movements be able to translate into function?
Okay.
So we work together well as a team here, the physical therapy department and the OT department, occupational therapy. We work closely together
As a team.
as a team.
How
So
did
it's
you
very
end
nice.
up here at Southampton? What's your little bit of your work experience and background?
I had done mainly private practice for years,
Okay.
and then finally wanted to come back to a hospital setting,
Okay.
and I had a very nice opportunity 3 years ago.
Oh, great.
So I've been here 3 years. I love it here. I like the way everybody works together. It's very nice to have that, you know, where you work close with the other departments, and everybody can work together with the patient.
And we're
It's a nice setting.
very glad to have you here, and I know
Thank you.
just the proximity with physical therapy right down the hallway is works out probably very nicely for the
Yes.
patients as well.
Yes, and especially the way
Right.
the insurance and the whole healthcare system is going. The hospital setting is a great place to treat a patient, because we still have that ability to spend that time one-on-one with a patient
That's right.
and give the patient what they need, and look at other things, not just in a private practice where you have a patient that comes in and you have to really see 4 and 5 people at the same time.
Right.
And at the hospital, we really have the opportunity to look at the whole person. And OT is very much about looking at the whole person rather than just the little individual problem they're having.
And from
So-
our overhead paging, people know we're actually sitting in the hospital today. I'm always amazed at the way the operators, every hospital I've ever been in, it sounds like the same operator
It
everywhere.
does.
There's a skill, I think, to that voice. Let's talk a little bit about occupational therapy and the types of injuries that you actually treat, and when somebody would end up seeing the occupational therapist separately from the physical therapist. Let's talk about the kinds of injuries first of all.
Yeah, occupational therapy, we see a wide variety of patients. We can have stroke patients or spinal cord injury patients, where we'll really get them in and try to restore their function. So we had a lot of neurological patients. We also have a lot of patients that have been injured, either job-related injuries, motor vehicle accidents, falls, where we do more of an orthopedic kind of approach. If they've had a fracture or they have any kind of tendon laceration, the occupational therapist will be able to make that person possibly an orthotic device like a splint. We have some to show you later, and be able to protect the patient. Then we'll start to do their therapeutic exercises, and then we'll build them all the way back up to function. So a patient, can come from an injury, or then we have patients that come from repetitive type of situations like a carpal tunnel or a tendinitis.
So office workers, people are on computers all the time, or I hear there's even
BlackBerry thumb.
BlackBerry thumb, exactly.
BlackBerry thumb, golfer's elbow, tennis elbow. So we deal a lot with that too. A lot of sports injuries.
And are you working with just the hands, or is it really the entire
The whole
arm?
upper extremity. Certified hand therapists are skilled. They have like an extra credential in working with the shoulder, elbow, wrist, and hand. So any upper extremity injuries, we have extra certification to treat.
And that certification, that's extra training that you have to go through?
Yeah, first you have to become either an occupational therapist or a physical therapist. You can do either. To be a certified hand therapist, it's very involved because they've kept it very small. They really want qualified people, and one of their requirements are you have to work in the field of occupational therapy or physical therapy for 5 years.
5 years, wow.
You have to do at least 4,000 hours in hands alone.
Wow.
And then you have to sit for a very comprehensive exam. And right now, I had done a little bit of research, and there's only about 5,500 CHTs worldwide.
I've heard there's a real
very
shortage,
small.
actually.
It's very small because it's such a specialized training, and you really have to love it. Like, I really enjoy what I do, so you have to want to spend that kind of time. But it's nice to have a specialty like that, because you really see.
You do, and you really get to, and the feedback I've heard from some of the patients is just amazing, that the work when people do have their mobility restored, it's almost miraculous, actually.
Right, because most of our patients will come to us in a great deal of pain, and almost immediately after the first session, because of certain techniques you can show them, they immediately have a feeling of pain relief. And they also know, because we can tell them with a good deal of prediction of what happens, because a lot of hand problems, what makes that nice is that everybody gets better. So you kind of have a way of making them feel comfortable, and you know the time frame, and you can predict, and it's a nice way to make them feel more comfortable.
Absolutely. And you actually have a lot of one-on-one time working with patients too.
You have to do hands-on.
A rarity in healthcare, actually. People appreciate the time just that they spend with their therapists, I know. Patients you're treating are primarily inpatients, or? Primarily
outpatient.
And how are they, how does somebody come to see a occupational therapist? Does it need a special referral, or what's the process for doing that?
The ideal process is that a patient who's having any kind of hand pain or injury has seen a doctor, and the doctor writes a script and then refers to us. The one thing we can offer that a lot of patients don't realize is that if a patient's having hand pain but is not quite sure where to go, like not sure which doctor, or do I go to a rheumatologist, is it arthritis, or is it something that I could be taken care of just by going to therapy, they can come for a screening here without a doctor's prescription. But
Is that
ideally,
something that's covered by insurance, the screening?
a screening or an initial eval would be covered by your insurance, and most hand problems are. But if you were to receive treatment, what we would have to do is refer you to the appropriate doctor, whether it be an orthopedic doctor, a rheumatologist. I guess what we feel the doctor would suit you best, depending on what kind of complaints you have. And then ideally we work from the doctor's prescription. So to actually treat a patient, we need a doctor's prescription.
And what's the typical length of a treatment? Is there a typical length, or
it does vary, but there's average time. A patient should expect to be here an hour for an initial eval, and then for treatments after that, anywhere between 30 minutes and an hour. We really base our treatment depending on the need of the patient. So if we have a very traumatic hand injury where there's a great deal of swelling, and we need to make like an orthotic device for immobilizing, the patient could be here an hour plus. But in general, we try to keep, once the rehab is going, about a half hour.
Okay. And over, it's multiple visits, I would guess, over weeks or?
Yeah, some patients up to 3 times a week, and it really depends on the injury or the diagnosis, but a typical length of stay would be somewhere probably around 6 to 12 weeks.
6 to 12 weeks, okay.
Would be typical for most patients.
And insurance covers the ongoing treatment as well. That's one of the first questions people would
Yes,
always ask
insurance-
me. Will my insurance pay for it? So,
And it's changing all the time, but
Right.
right now, most insurance companies will cover all hand therapy.
okay. So what are the most common kind of injuries that people come to an occupational therapist for?
Well, carpal tunnel still
Okay.
remains one of our
Yeah.
uh,
What is carpal tunnel exactly? I should know
Car-
this. I mean, I vaguely know
Right.
what it is, and I know people who use computers.
And
tend
a
to
lot of
get
people will come in and say they have carpal tunnel, and they don't really.
It's
I mean,
not,
it's like a
yeah.
catchphrase for the
Yeah.
patients. But carpal tunnel really is a nerve compression. It's the median nerve compression.
Okay.
And symptoms from carpal tunnel can be the same symptoms that is coming from a neck compression, an elbow compression. So a patient who comes in, sometimes you really have to look at to see if that's really what they have. Because sometimes they've gone to their primary doctor and said, I have carpal tunnel.
Right.
You know, and then they come in and we can examine them further and see. But it's really a nerve compression, so you have to work on teaching the patient proper techniques.
Right.
We use different modalities. We're lucky at Southampton because we have a cold laser, which a lot of therapy places don't have yet.
Cold laser?
It's cold laser.
Yeah.
It works at like a cellular level as
Okay.
opposed to ultrasound. But we're able to have both systems here. They're both very successful in a before surgery situation.
Okay.
Sometimes if the nerve is compressed severely, nothing besides surgery will help.
Okay.
And then, you know, the patient will be in contact with their surgeon and they'll decide to do surgery. And then a lot of times we do post-op care also for carpal
Right.
tunnel. So we can be valuable before surgery and after surgery for carpal tunnel patients. And that's an ultrasound machine and a laser machine.
And that's a hand, actually.
that's a hand.
And the hand is actually, I've been told it's one of the more complex parts of our body,
It is.
actually.
It is. Between the wrist and the fingers, there's 26 bones.
26.
26
Wow.
bones. A very intricate extensor and flexor tendon system.
Right. And a lot of nerves running
A lot of
through it
nerves.
as well, right? when you
Yep, we have to
consider-
be able to feel and discriminate everything we touch. So
Right.
it becomes a big problem when it's injured.
Yeah.
So if you have a nerve injury, a tendon laceration, it's very complicated. And that's why what they tried to do it being a CHT was go away from just, you know, really the hand surgeons want a CHT rather than just a regular occupational therapist because you have those 5 years experience. You have that comprehensive knowledge of how to get the patient back to,
Of all the structures.
yeah,
and
of all the
things.
structures, exactly.
Is it therapy that's usually happens before surgery, after surgery, or is it really both?
It could be both.
Okay.
For certain injuries, like a repetitive injury, like like a tendon injury or carpal tunnel, if it's a mild case, therapy, a patient can really benefit and possibly save them from the surgery.
Okay.
If it's a very severe case and you've tried therapy for a short time and you see that they're not getting better, then you know you have to talk with your surgeon and say, look, we've done this. Patient doesn't seem to be getting any better. What's their next option?
Okay.
And then sometimes cortisone or surgery is the next option.
Okay. And cortisone just to reduce swelling, I guess.
Exactly.
Okay.
Exactly.
Now, are you able to assess the source of it? I mean, if somebody gets their hand fixed and then they go right back to the computer keyboard and potentially just redamages themselves, do you work with them on changing sort of their
Yes, certain-
lifestyle or whatever as well?
Okay, so when you have a patient who has a tendinitis or a repetitive strain injury,
Right.
you really want to educate them because you want them not to have this happen in the future.
Right.
So that comes into play a lot with arthritis. When you
Okay.
know you have an arthritic hand, that now this person loves to garden and they constantly are using it in some way, if you educate them to protect their joint, you can actually help them to save the breakdown and not have pain in the future.
We live in a very vacation spot, lots of sports, lots of golfers. Do you see people that are also developing, or a lot of tennis players? Is tennis elbow something that can be helped, and some of
Tennis,
the golfing injuries
yep.
as well? Or?
Both of those injuries are very common, and
Okay.
they're hard to treat because what happens is when they have such a severe pain like that, the first thing you have to do is get rid of the pain. So
Okay.
before you can strengthen the muscles that will help that in the future, you really need to get the pain down. So
Okay.
so therapy is very beneficial because we can use the anti-inflammatory modalities like we had talked about, and reduce their pain. And then we have a very good program where they can strengthen the muscles so that they don't get those problems in the future.
Right.
And that's what we're hoping to educate a lot of patients about too. If they are a big tennis player or a golf player, we're hoping to show them programs where they can keep their muscles strong enough so that they're not going to get that type of injury.
Okay.
And that's what we're working on now too in a lot of our programs, to try to help them before they get the injury.
The traditional kind of sports approach, I know myself when I've played or had coaches when I was in high school, it was, well, pain is good, it shows you're progressing. How do you feel about that?
In hand therapy, we don't really believe that.
Okay.
You want to work within the pain tolerance. Pain's usually the body's response to say, you know, we don't want this.
Enough is enough.
And when you respond with swelling, it's always bad. So we try to keep, you really don't want to push to the pain level.
Right.
So if you understand like the proper mechanics and you can stop it before it gets to that point, it's much more beneficial.
So somebody who's playing tennis or golf or something and they've developed this chronic pain, it's probably your body telling you it's time to do
and then
something about
it. And then if you take care of things early on, like that's probably one of the biggest problems, is that the people who do love golf and tennis don't stop until it's really bad.
Okay.
So if they can like look at their body and say, oh, I do have this pain that keeps reoccurring, and get help or go to therapy, they can really stop a bad injury from happening.
And some people I know, there's a little bit of a superstition, well, if I go get health care, I'll have to stop playing tennis, or it'll be, I mean, probably the opposite's true, right? If you teach them better techniques, they can
they can prolong it for
improve
sure.
their game, so,
There's a lot of good stuff on the market too, things that can be a support to them, things that can help. So they should definitely get help as soon as they notice a problem.
Okay. A lot of us are in the baby boom generation and aging and noticing more and more twinges and pains and aches, and you know, and some of it's arthritis, and is that something that you can work with as well?
Yes, we do a lot of patients that have both types of arthritis, osteo, which is more of what you're talking about with through the age, and then we also deal with rheumatoid arthritis. And what we find with is teaching people about the joint protection and doing certain activities a different way really helps protect their hands. Sometimes just you're not going to be able to stop the progression of it, but you'll be able to relieve the pain and teach so it doesn't get worse. So sometimes a patient will come to you and they've done for years, they've done a certain activity, gardening or something where they've held tools, and their bone is practically bone on bone now.
Right.
But we also can use certain splinting techniques to, at least if the patient doesn't want to go the option for surgery, that will help protect that so their grip and they can still function but without pain.
Okay.
And we can also maintain their range of motion. So hand therapy is very valuable for those patients with arthritis.
Okay. I know that one of the things that occupational therapists do, and hand therapists in particular, is develop prosthetic devices and other things. And you said you may have some of those that you could show us, or be
we do.
interested to-
We do a lot of different orthotic devices.
Right.
So what we do is
And are these things you make here, or they go somewhere else for it? Or
we make all kinds of custom things here. So if we have a patient who maybe like just a simple carpal tunnel, and we want to just like immobilize their wrist in a neutral position because that helps. We'll take a
And what's the
piece
purpose
of
of immobilizing? Just the motion is
rest.
what's... Okay,
Yeah.
okay.
So most people at nighttime will sleep with their wrists flexed.
Oh, really?
So if you put something to just keep their wrist straight, sometimes that's enough to keep the pressure off the nerve.
Oh, okay.
And if you do that for a few weeks, sometimes the nerve opens up. If you think of it like a garden hose,
Right.
and you have pressure on that hose
Like
for a
you've
long
kinked the hose.
Yep.
Or, yeah.
The hose stays kinked, but if you take that pressure off it, it might take a week or so, but that hose will open up.
Okay.
So by taking something like this, we make a pattern, we cut it, we take a piece of low temperature plastic, and everybody's hand is different, so we make it custom to their hand.
Okay.
It's molded very nicely. In arthritis, this is a type of splint one of the students had made. For an arthritic hand, what they do is, this doesn't fit me because it wasn't made for me, but it'll mobilize that CMC joint, and it will actually allow the patient to pinch stronger without pain.
Really?
So we've done situations where we'll take the patient, we'll have them pinch, and we'll measure it. And we'll make them an orthotic device, and we'll have them pinch, and we'll measure it again. And besides their pain level going down, they were also much stronger. So if we can take these materials and we make things custom, we can solve their problems. So this was designed for a patient who had a spinal cord injury and lost the ability to straighten her fingers. And what happens is when you put something like this on, it uses the rubber band traction to get you the movement of the fingers that you've lost. So by doing all different kinds of orthotic devices, or splint, we used to call it splinting, now they're trying to just call it orthotic devices, you can really tailor what the patient needs because we can do everything so custom.
How long does a patient typically need to wear one of these, or is there a...
It varies a lot. Something for like a post-surgery, like maybe they did a fracture and then they have to go into a splint rather than a cast. It might be 4 weeks or 6 weeks. A tendon injury might be 8 weeks, you know, so it depends. But an arthritis splint, something that helps protect their joints, some people will come back yearly for new ones. They wear it all the time because they don't want to have surgery and they want to just keep using their splint.
Keep the strength. Does that apply also for elbows and shoulders? Are there things you can do too?
For elbows, we do some splinting, but we don't do really any kind of splinting for the shoulder yet.
So people who've had a severe injury of some sort, a burn or a fall or a break or something, I guess what is the outcome for that, and how can you treat those injuries? Can you treat those injuries?
We treat the time that we can treat burns most successfully is to prevent them from scarring and forming contractures. So some people who have had very severe burns, once they're done with their acute care, they'll come for splinting or for pressure garments. You want to try to keep that joint wherever they're burnt across from contracting. So occupational therapy and hand therapy is very beneficial for patients who have had burns or any kind of traumatic injury like that.
And how soon after somebody's had surgery, if they've had, you know, wrist surgery or something, can they get therapy?
Now there's certain doctors here at Southampton that are doing very advanced surgeries, and they're putting open reduction internal fixation. They're basically taking hardware and they're making the bone strong that way. So where we used to have to wait 4 weeks to start movement or 6 weeks after a fracture, when the doctor's doing surgery, they're actually having the patient come in the next day. And the next day we're getting them into a splint for protection, but we're also doing very purposeful movements so that they don't get scarred down and that they don't lose their movement. So with the new techniques coming out in surgery, we're starting therapy much quicker than we used to.
And I know in a lot of healthcare, when people had surgery, the old myth of bed rest and immobilization for extended, that's kind of going out the window. Is that true a lot with surgery as well?
With most.
Yeah, with most of that.
Get them moving as soon as possible.
And get people back to normal. Age limits that you work with? Any?
I've worked with a 3-month-old, and I've worked with people well into their 90s.
Have you really?
Yeah.
Well, that's good. It's amazing how much we depend on our hands without even thinking about it too. I know I've spoken to some people that have lost mobility in their hands, and basics from eating to tying your shoes to just getting yourself dressed in the morning. It's an amazing. You do devices and things to help people that get through that as well?
Yeah, because sometimes no matter what you do on the rehab end, patients are still going to have disability. So we look at the whole picture. So what we have to do then is, if they're still not going to be able to do something, we try to get them a product possibly, or a company that can bridge that gap. So because sometimes no matter what you do, somebody is going to have a deficit in the end. And then we need to get them set up so that they can function as normally as possible. And we do help with that too.
You give people exercises they do at home and things? It's not only here while they're in therapy? Are there things that
it's
people
not only
can
here,
do?
it's at home, but because that's where a lot of their progress has to be made, because we'll see them maybe 2-3 times a week, but a lot of these hand injuries really benefit from a patient doing something 2 or 3 times a day.
Oh, really?
So they really need to be taught a good schedule, and you can see the difference when you have a patient who really does their home.
Probably a lot of it depends on motivation, I think, right?
Yeah.
A lot of
the golfers are the most motivated.
Are they? Yeah, I bet they are. Do they expect you to take a few points
I
off
always
their
tell them.
game,
I always tell them, you can take a few strokes. If you follow this, we can take a few strokes off.
That's good.
And they love to hear that.
That's out here. I'm sure that's very very popular advice.
Yeah.
all of the technology that we're using, it seems like everybody's on a keyboard and everybody's on cell phones and Blackberries or Apple, whatever device. Everybody's how. And I hear about repetitive wrist injury frequently. How real a phenomenon is that really?
It's pretty bad. I was just at the Philadelphia Hand Conference, and one of the surgeons had put up a slide, and a young gentleman, age 12, he put it up, and he actually ruptured his extensor tendon of his thumb from playing a video game.
Really? Actually, that sounds
Actually
very
ruptured
painful.
it, and
Wow.
he had used that as a case study, and it was from playing the video games.
And kids are on keyboards and computer devices at a very young age now, so
Yep.
it's got to be a
It is.
big risk.
It's a definite problem.
Do you have any advice that you would give somebody on using a keyboard, or are there? I sometimes see those foam cushions people
Yeah.
put. Is that
Basically, the best thing I could say that I've learned over the years with that is change of position. So
Right.
even if you have to do an activity all day long,
right?
even a short break, a minute break, 30 seconds, where you change position, you alter what you're doing, is helpful to the tendon. You don't want to get in the habit of doing the same motion constantly, over and over and over. If you can break up the activity even a little bit, it's valuable.
Any things if somebody's in a field where they're on a keyboard all the time, or even some craftsmen that are using
Yeah.
power tools a lot, is there anyone ever come see an occupational therapist just before the real problem develops to get advice on how to use it, or?
We try to do more of that with companies and
Okay.
just educating the general public, because there's certain things that will make a person more susceptible to getting those injuries, like machinery with vibration. So
Right.
sometimes if the companies can cut down that, or and then like set up the workstation. I know like here at the hospital we have a good program where we can go around to do an ergonomic situation. So if an employee has a complaint, we can go and we can look at their setup and we can be of help. Occupational therapists are trained in that too. So
Right.
if a company or is interested in like figuring out the best height of a desk or something like that, occupational therapy is helpful for that too.
Can make a difference for them.
Yeah.
Exactly right.
Yep.
Well, I know we've just run out of time, and I really want to thank you, Nikki, for
Thank you.
today's program, but also for the great work you're doing here. I've heard your entire department really is making a difference in the lives of very many people, and I know
That's nice
you
to
want to
hear.
tell us about Occupational Therapy Month is
That's
happening
right. And,
also?
April happens to be Occupational Therapy Month, so we're excited about that. We're going to do some community service for that, and just try to make everybody aware that occupational therapy could really help.
So I guess I would say an occupational therapist, make sure you go up to your occupational therapist and give them a firm handshake, and if
That's
you
right.
can, ask them what's wrong and how to help you out.
Exactly. Very good.
Well,
Stu.
great. Thank you very, very much for all the good work that you're
All
doing
right. Thank
here.
you.
And if any of you have concerns or need advice, have problems with your hands or upper extremities, please call our physical therapy department. They'll be happy to get you set up with Nikki or a member of her staff, and that number is 631-726-8520. And then I'd like to wrap up by just thanking again our friends at CTV for the great work they do in producing this show each month, for our friends at LTV for airing it, for our East Hampton communities, and for all of you for tuning in and giving us advice on programs that you'd like to see. If you'd like any additional information or help navigating our healthcare system out here on the east end of Long Island, please give us a call at 631-726-8555. Thank you, everyone, and good health.